So, hi everyone, good afternoon and welcome to the Northern Cancer Alliance and Cancer Research UK Safety Netting webinar. We have a partial team of cancer research facilitators this afternoon. We have myself, Sarah, Sharon and Pete. We've also got Katie Elliott, who's the Northern Cancer Alliance Primary Care Clinical Director and Cancer Research GP, and Chris Tasker, who is also a Cancer Research GP, both who I think you've met before on previous webinars. So, we have clear objectives for today, and we're hoping by the end of this session, you'll have the opportunity to reflect and review current safety netting activity within your practice to highlight what works well. Discuss and identify cancer safety netting actions to implement within your practice. And thirdly, to increase your awareness of health professional resources to aid the recognition and referral. So without further delay, I'd like to introduce you to Katie Elliott.
Hi everybody, thank you for the introduction, Sarah, that's great. We're talking about safety netting and in its different forms. And one of the priorities and one of the reasons this is a hot topic at the moment is because obviously it's part of the PCN DES. We'll be talking as well about how to achieve the PCN DES and what the requirements are for the PCN DES. So we'll just move on to the next slide, thanks. Just a quick reminder to everybody just to stay on mute, please, if you can, and we'll make opportunities for people to speak later on. That's great. So we know about safety netting, so it's something that we do all the time in general practice, and we do the sort of clinical safety netting where we talk to people and give them advice about what to expect and when to come back and see us. And there are also things that we do in practice all the time to follow people up. And the overall sort of description of that is this diagnostic management strategy that means that we keep an eye on patients and monitor them through a presentation of their illness until we either know what's happening or we've reassured them that there's no other actions are required. And it's that clinical and process safety netting that go together to help us actually do that. I think what we know is that probably that's slightly different in different practices. People have different processes and different approaches to it. And we'll cover some of those different approaches in the breakout rooms when we talk later on. Next slide, please. And this is a reminder as well about the medical defence organisations' thoughts about safety netting as well. So again, recognising that it's about people presenting at different stages of their illness and needing follow-up to identify if further action is required or identify complications, but also the systems that we have in place to monitor and follow up people that we've arranged for investigations or actions to happen. Won't spend more time on that, but I think just highlighting that element of the medical defence organisation side of things as well. So while we're having a look at this slide, we'd actually just put up our first poll, which is just asking about you, to ask you, do you have systems already in place to safety net, for instance, 2-week wait referrals or investigations? So if we just put that poll up, thanks, Pete, and then we can have a look at the slide.
You should see a poll form just pop up in front of your screen there. So if you just select the option that's best suited to your answer and then click on submit. And then once you've clicked submit, you can close that box down in front of you and we can see the results in the chat box area. So
safety netting in relation to cancer, obviously we've got some more specific activities. So some people who present initially with symptoms of cancer, we know straight away that an action needs to be taken, and that often happens very quickly. And other times there's more difficulty making that clinical decision about either which investigation to choose or whether to make a referral. And we might arrange initial tests in primary care and then need to follow those up. So that's that sort of clinical decision making and the safety netting that we might need to think about the tests that we request. And then, as mentioned, there's the PCN DES, which is very specifically looking for safety netting around 2-week wait referrals. So wanting us to improve our referral processes for suspected cancer with a focus on safety netting. So that includes patients receiving the information that they need about the referral, but also the process to check that a referral has been completed and somebody has been seen. And this follows on a little bit from some of the QOF work last year around safety netting referrals, and you may find that the work that you're doing this year is building on the actions taken last year. And of course the significance as well of safety netting for CQC. You know, it's a really good piece of evidence for CQC when they come to see the practice. Can I just double check, did that poll work? Sorry, I must have a different view of the chat box because I haven't been able to see that in the chat box. Can anybody?
Okay, I'll give you a bit of a summary of what the results are there. So the responses so far are 32 people filling that first poll in. 44% of people are saying in response to the question, do you have systems in place to safety net referrals and investigations made by locums? 44% have said yes, and we make sure locums know our safety netting practices. 38% have said yes, but we don't know if locums are doing the same as everyone. And we've had 19% of people say they don't know. And there's another poll that's just popped up on your screen there, which is asking, when it comes to safety netting, do you have systems in place to cover for both expected and unexpected absence? So if you just select your answer for that one as well, and that one, once you click submit, that should disappear into the chat box as well.
So again, this is about contingency planning. So any process is only as good as the exceptions that you have to make to it, and how you manage those. So and you know, and this can happen to any of us, and will have happened over the last few months that people have been away from practice unexpectedly, and we always have the challenge of how we manage actions that have been taken by locums and spotting follow-ups required from that point of view as well. So Pete, just let us know when that poll's complete. I'm sorry, I can't see the results of any of this. I can't see anything in the chat box at the moment.
All right, I'll cover that one. Yes, so there's 28 responses so far, and 29% of people saying yes, hand on heart, everybody knows the system, it's now a blood. 38% of people are saying yes, but nothing's written down, it's just learned behaviour. We've got 3% of people saying no, and 28% of people currently saying don't know.
Okay, thanks very much for that, Pete. So, you know, again, the safety netting is nothing new in general practice. You know, we do it all the time, and the importance of it and the work that the CR UK team have done with practices over the last few years, hopefully has encouraged that sort of uptake of practice and process in general practice. And hopefully what we'll be able to share later on in the breakout groups is some other sort of practical ways of implementing safety netting for those that haven't looked at it or who want to look at having a more systematic process. So we just go on to, we're on to the next slide, that's great. So the PCN DES specifically around safety netting patients with that have a 2-week wait referral. So another poll at the moment, do you use an Excel tracker sheet at the moment to keep an eye on on your 2-week wait referrals?
And again, that poll's live on the system now, so you should be able to answer that question as well.
So until a patient is contacted or seen by secondary care, their care remains the responsibility of general practice. So I think it's just being really clear that, you know, particularly a failed contact with secondary care isn't always an informed decision. There may be other reasons that the patient has not engaged with a referral, and you know, it's our role in general practice to make sure people are being supported appropriately to take up an offer of an appointment if that's been recommended. We've understood the referral.
Responses so far on that one, Katie, in terms of people do you use an Excel tracker, we've got 67% of people saying yes, we've got 30 responses so far, 23% of people are saying no, and 10% saying that they don't know. I'm just going to put up the second poll now, which just asks about how do you keep track of patients with unresolved symptoms?
So again, this goes back to the way that people present, and that often initial presentations can be a little bit unclear about the source of somebody's symptoms, and whether you arrange some initial investigations and then review those, whether you give somebody a planned review to come back and see you, or whether you leave it with the patient to get back in touch with you if the symptoms persist, or depending on what the advice is that you've given. So it'll be interesting to see what the responses to that poll are. So
kind of the responses are coming in for this one thick and fast. 18 responses so far. 31% of people are suggesting that they book a review with a clinician. 45% of people are saying that we tell the patient to contact us if the symptoms don't resolve as well. Just remember, it's a multiple choice response. You could have selected a few different things. 17% up to 18% now task to self or to group. We don't presently have anyone saying other, so there's nothing yet to share in the chat box. Little 5% saying we don't track, and then a further 5% saying we use an Excel tracker.
Okay, thanks, Pete. And again, one of the lines in the NICE NG12 suspected cancer guidance is about ensuring that there are local arrangements in place to identify people who miss their appointments so that they can be followed up. So you know, that obviously applies to the 2-week wait group, who should be notified if somebody doesn't engage with an appointment, but also, you know, we should be thinking clinically as well about people who we're expecting to see back who don't show up or booked an appointment and don't attend. Again, it's not always an informed choice and may be affected by people's physical or mental health issues that are preventing people from engaging with us. So next slide, please. So some key points here: communication with patients around safety netting, for 2-week wait referrals, particularly around attending people that they understand that they need to attend an appointment, that people have received appropriate information about the referral, and that the information that they're given is appropriate for them. Talk about that a little bit more in a minute. From the clinician's point of view, and it says GP on here, but we absolutely recognise that there's nurse practitioners as well who see people and make referrals. So check that the patient understands the advice that they've been given, and think about accessibility of that information, and actually document and detail the safety netting advice in the medical notes as it's understood by the patient. Basically, the advice again from medical defence organisations is if it's not written down, it hasn't happened. For the PCN DES, the key metric that's being looked for is a safety netting code, and the code is included here on the slide. So these are the actions for practices about understanding how to use the safety netting code and how to have a process in place to not just use it, but to follow up as well. And the other action for practices as well, think about having active management of DNAs as well. So when people haven't attended a 2-week wait referral or investigation, how is that actively followed up? Next slide, please. So back to that communication. One of the most frequent SIRMs, so significant events on the reporting system for general practice, is when a referral has failed because somebody's filled in the form but not sent it off, or not told the secretarial team that it needs to go. And what we also know is that from those incidents, there are some practices who are able to spot that sooner, and others where it can be a lot longer, or it can be months before it's flagged up. And what seems to make the difference is when patients have had really good information about what to expect. So the patients who are told to expect to hear from the hospital within a certain amount of time, and what to do if they don't hear, we pick up those issues much quicker and they're resolved much quicker, and there's less delay for the patient. If they haven't been given the information, or if they don't understand that information, it often leads to a delay before somebody gets back in touch, because the patients are just waiting to hear from the hospital. So the patient information leaflets, we can send those in different ways. We don't have to have them printed out and sitting on our desks. We can print them out as we need them. From the Northern Cancer Alliance website, we can attach a link into a message to the patient, and a lot of us are using AccuRx at the moment to send messages to patients, and attaching the link is a really good option, because where these patient information leaflets now are hosted on the NCA website, there is an accessibility platform built into the NCA website now, so that people can access those information leaflets in different languages. You can change, it can be read out, the font size can be changed, there's different filters that can be put on to help people with reading. So it means you don't have to have this translated locally into lots of different languages. If you use the link that's there on the NCA website, you can get an accessible format. There is an easy read version as well, but something that we've also thought about quite carefully is, as well as trying to aim for a reading age of 9 to 11 for our patient-facing material for the NCA anyway. So the link for the safety netting, for the link for the patient information leaflets is on every 2-week form, and it's on the front page of the Northern Cancer Alliance website. So that's one of the things you could bookmark on your system if you wanted to. Okay, next slide, please. Okay. So you may already be doing this. So you may already be keeping a log of your 2-week wait referrals with an Excel sheet, and somebody who's then updating the spreadsheet weekly with the date that somebody's seen in secondary care. If there's no letter to confirm they've been seen within 4 weeks, maybe somebody then contacts the patient. So this may be the kind of thing that you already have set up, and that's great. For the PCN DES, so it's looking for this code. So we need to think about how we can fit the safety netting code into your process, and also how do you document the information that's being given to the patient. So going back to what we discussed before about the patient information, if you send the link on an AccuRx, that will be automatically recorded in the patient information, sorry, in the patient record. So that's one of the ways to record that the information is given. The other way is using templates in the GP system, and we'll go on to talking about that as well. Next slide, please. So what we would suggest is, that there are different platforms, there are different tools that can be used to support safety netting, particularly around the referrals, but there may be some minimums to think about. So communication, obviously telling the patient about the urgent referral and giving them the patient information leaflet, and consider that accessibility element and use the NCA website link. Document that you've told the patient. So that will happen automatically, as I say, if you drop that into an AccuRx message and save it. Think about having a template for your referral forms, so that it automatically adds the SNOMED code to say that safety netting has been done. Or that code could be added at the time when the referral is actually sent. Thing with adding a code is it's all very well as long as you actually then do something about it. So you could code everything, but unless you've actually then closed the loop with the safety netting, you haven't actually done the safety netting part about it. So for the practice, what you need to do is work out what is your system to make sure that that appointment is complete. And again, there's different tools that are available. We've talked about, the basic spreadsheet, and that's probably a minimum requirement if you for doing this, but there are some safety netting templates that are set up in EMIS and SystmOne, and some people have already paid for things like Ardens and See the Signs, which also have their own safety netting systems as well. So this is something that will for everyone to think about. What's your process? How does it work? How reliable is it? And for a practice, what is your process for managing DNA letters as well? And just remembering it's not always informed patient choice about that. Okay, next slide, please. So
thanks, Katie.
I'll hand over to Chris to have a think a bit more about the data as well.
I'm going to quickly go off track just to cause trouble. There's some questions on the chat about hosting the forms, using old forms. Both SystmOne and EMIS, you should be able to get your forms which are up to date but kept on the practices. So SystmOne, we use a practice in Durham, and EMIS use one in Gateshead, and you can sign up in such a way that when you select a form, it comes from those practices, and that will ensure you always get up to date. So I think Denise put a question there.
Talk to that. Sorry, I can't see any of the questions, so people will have to tell me if there's stuff we need to cover. So yes, for SystmOne, your 2-week wait forms are, if you've joined the DCS group, then the 2-week forms are available centrally. Any changes that are made happen automatically, so you always have the most up-to-date version. The issue is if you have an add-on like Ardens, and you're using or Pathways or something like that, you need to tell them that there's so when we send the alerts out through the CCGs that there's been a change to the forms, you need to let them know so that they can update them for you. Okay, but everybody already has access to the most up-to-date version through the DCS group for SystmOne, and now through Resource Publisher for EMIS. Now, if you're in EMIS practice and you haven't got Resource Publisher switched on, I would highly recommend that you do that, because there are other resources that are available through that as well. So again, just making sure that you've always got the most up-to-date version, and you don't have to archive and reload the referral forms each time they're updated.
Just to say, your local facilitator, facilitator will help you do that if you're having a problem doing that.
Thanks very much, Chris and Sarah.
Thanks, Chris. Let me know if there's any other questions.
Will do. Next, we're going to have a look at the PCN dashboard. The PCN dashboard looks for this code. It's only updated every 3 months. So these figures are out of date, and these are the latest figures, March of this year. But it does show that in practice in County Durham, it's from 0 to 34% of practice are adding this code to their notes, as well as doing a 2-week referral. So it shows there's lots of room for manoeuvre. I don't think most practices are aware of this, but obviously it's not just, as Katie says, not just about adding the read code. It's about having a safe netting process behind the read code as well. But that's the way that we've been measured in our PCNs. And yeah, so we need to start using these codes if that's okay.
And Chris, sorry, I know you said read code there. I'm just picking up that it's a SNOMED code now. So probably everybody knows that we've migrated away from read codes to SNOMED codes now. So the new code is a SNOMED code that needs
That's
to
grey hair. I'm old-fashioned.
I'm just going to jump in there with a quick poll. I'm going to ask another poll question, and that is simply: are you using the SNOMED safety netting code? You should see the poll pop up onto your screen there to answer. And feedback on that. So great response on that. Yeah, 60 straight up, 9 responses so far. 65% saying yes, 24% saying sometimes, and a smaller percentage saying no or don't know. And I'm just going to pull up one final poll around this one here, and that is: are you actually aware of the PCN dashboard? Just for our own understanding there, that would be great to know. There's a lot of responses there initially saying no. It's the first time they've heard of it straight away.
So I think this is a slightly frustrating thing that people will feel, is that they may be doing it, having really effective safety netting processes, but because the code is what's being looked for, it's not visible. and equally you can maybe add in the code but doing absolutely nothing about it, in which case your safety netting process is rubbish. So you need both bits of it to work. The PCN dashboard, as I say, it's a bit clunky. The last time the data was updated was March. It's supposed to be quarterly, so this is not, it's not live. It's not as useful as we would like it to be, and we've fed that back to the national team about that as well.
Brilliant. Next, we're going to go into our breakout rooms. There's going to be 2 breakout rooms, one for SystmOne and one for EMIS. And we're going to look at more details of these different types. So for half an hour, we're going to do this, then we'll come back and meet together again to look at some clinical situations. So if you could please press on the appropriate link, that should take you through to the right place. And then we'll see you all in, well, some of us will in each room, otherwise we'll see you in half an hour.
So what we're going to do in this room first, we've got 2 fantastic speakers. One's going to be virtual, and we've got George here as well, George Calder from Valen's Medical Partnership, Dr. George Calder, apologies. And another person who was going to be delivering to us was Emily Welsh, and she's a primary care information management and technology facilitator who has built a SystmOne template system. She can't be with us today, unfortunately, but she has provided a bit of a recording. So what I'm going to do is I'm going to load up the recording and just play that video first for you, so you've got a bit of an awareness about it. So I'll just bring that up now.
This short video will talk you through the functionality of the LLR Cancer Safety Netting Toolkit, which has been created for clinicians to use throughout a patient's cancer journey, from presentation of vague symptoms all the way through to diagnosis or other significant diagnosis. Here we can see the LLR Cancer Safety Netting Toolkit. It starts out with a brief introduction about what the template can be used for, an index which takes you directly into the other pages of the template, a quick action which takes you through to the 2-week-wait administration toolkit, which has been created for the administration staff to use when sending a 2-week-wait referral, and further down are some useful links that clinicians may find beneficial to support the safety netting process. Moving on to vague symptoms, the first section is to record that the patient is being cancer safety netted. By ticking this box, it will add a read code into the patient's record. You can then add what your consultation notes are and what your examination notes are. There is then a list of common vague symptoms that you can select from. By selecting an individual symptom, it will show you in this panel here if the patient has presented with this symptom before. It will also show you if a patient has presented with any of the above symptoms in this box here. You can then record any other symptoms that may not be listed above. Further down is for you to organise a follow-up. By pressing this button here, you can choose from a preset note, and we can say the patient wants to be followed up in 2 to 3 days. That will then get added into this box, and it will also read code active monitoring. You can then select from a couple of options for you to organise the follow-up. You could send a task, or you could go directly into the appointment ledger and book the appointment. Moving on to referrals, here we can record any new and ongoing symptoms, and we can also record and refer the patient for any investigations. We can record the history in this first box, and we can also read code any new symptoms as well. Further down, you are prompted to make sure that the contact details are up to date before you make a referral. You can add a new address, and you can add any new contact details here. You can also update the smoking status and update the alcohol status as well. On the left-hand side, there is a list of common direct access diagnostics. We can tick from a number of these options, maybe a blood test and an X-ray, and we can then tick the date of this referral. A bit further down is then a quick action directly into ICE to make the referrals, or a referral letter, or an electronic referral, for example, a referral to the district nurses. On the right-hand side is for fast-track cancer referrals. You're prompted to make sure you give the patient the 2-week-wait "Why have I been referred" leaflet. You can then choose from a different pathway, and again the date that you're doing this referral. And you can then go directly into PRISM to make this referral, or you can go straight into the e-referral service. There is then a number of options for you to click from to ensure the patient is followed up. It may be that you want to set a recall, you may want to book their appointment, or you may want to send a task. The last page is results and confirmed diagnosis. In the first section, you will see all pathology and radiology for the last 2 years, and you can also add any other necessary results on this side as well. Further down into cancer diagnosis, if a patient has already been recorded with their diagnosis, it will show up in this box here. If it is not showing, you can add it as a new major problem. You can record a metastatic disease, and you can record that the patient is aware of their diagnosis. There is then some information about the cancer care review template, which now needs to be done within 3 months of a diagnosis and also 12 months of a diagnosis. These buttons will take you straight into the cancer care review template, and there is also a quick action to cancer connections and also the integrated care planning. You can then add what the patient's consent is for the summary care record. Further down, if the patient's diagnosis is not cancer, you can record that as an other non-cancer diagnosis, and then you can use the read code browser to record any other significant problems. This section will be for remote monitoring, which isn't going live until February 22.
All right, I'm just going to stop sharing that screen there. I'm hoping everyone's just been able to see that video, and I haven't just been playing it to myself on there. But yeah, that's by Emily down in NHS Leicestershire, and if that sparked any interest to anyone, she's very happy to share her email to have discussions and going forward. And those templates have got to be shared as resources that you can utilise yourselves as well. So if I can hand over to George now to share some information as well.
Thanks. Did someone have a hand up for a question there, or?
Yeah, all I can hear is a conversation between other.
Are you on the Teams?
I can hear a conversation.
I'll have to do the same as you. Just say, I've already got the link
About
to SystmOne.
somebody who can't actually get onto the right chat room, the right room.
Can you just look at me?
And I don't know if anybody else is in the same situation as me.
I think I might have to end this to find the calendar. So
you second, yeah, I'm just hearing the conversation now.
And I hope to see it. All right, if I don't, I'll have to catch up.
We can only hear it when you've got your.
So I don't know if anybody else can hear what I'm hearing, which is a conversation between.
Yeah, I think it's only happening to you. Can you just
Okay,
the link to go back in again?
Why that is.
Next, let me see if it works this time.
Just joining there. Sorry.
So I'll go into my emails.
Are you able to close your link and come back in again, Amber? Pete, I had some problems getting into the room as well, so I hope we haven't lost people
Right, okay.
on the way.
So, can I confirm there's everyone who's in this room presently? Have you been able to see the video that was started at the start, or has that not worked?
Yeah, it worked.
Yeah, I could see that.
Yes.
Yes, thanks.
Apologies for the noise that was coming through there. I'm not too sure what's happening there.
That looks like that's happening for somebody else as well, unfortunately, as well as Amber. So, yeah, I'm sorry about that. We'll see if we can resolve that. I think if we hand over to George at the moment and see.
Yeah, if we hand over to George, I'll work in the background to see if I can sort something out there.
Yeah, okay. Thanks very much, George.
Yeah, no problems. So, yep, I'm George Calder, so I'm the cancer lead for Valens PCN. So we're a single practice working across 8 sites. And we made some changes on the back of the cancer audit that was done, really around safety netting, because looking at that was something that we felt could be done a lot better. And again, looking at the information, it was done quite differently across all of our sites. So we wanted to try and find a way to sort of streamline things, really. So we came up with a template, and the idea behind the template was to address these issues and really to try and make clinicians' life a bit easier, because we felt that if it wasn't something that was a benefit for clinicians, it probably wouldn't be used. So the template itself has the 2-week wait referral criteria for each cancer. So it can be used for reference because the guidelines can be quite difficult to remember sometimes. It also includes all the codes for safety netting and for giving the written information, and it means that everyone's doing the same, including our locums. They're all advised they should make their referrals using the cancer template. So currently we've got over 40 clinicians using this at the moment, and the feedback's been really good. And the other side to it is that it helps our secretaries, because they're actually getting all their cancer referrals through in the same way. So it reduces error from that side of things. So what I'd like to do would be to walk through the template. So I will attempt to share my screen. So you should be able to see a test patient in SystmOne with our Valence cancer templates. I can see Pete. Can you see that, Pete? Yeah. So what I'll do is I'll load up the template for the lower GI pathway in a second. The rest of the cancers are all there by cancer type. And then at the end of the template, we've got a tab for some resources such as Q Cancer and mind maps. And then the other thing we've got is a link to the Macmillan Cancer Care Review template. So the idea is all things cancer can be done from our cancer template. But if I bring up the lower GI template, so like I say, this is one of the guidelines I find more difficult to remember. And so really at the top of the template, all of our templates are laid out in exactly the same way. So there's familiarity there, but at the top of the template are the 2-week wait referral guidelines taken from the Word documents from the Northern Cancer Alliance. So the details are current, so it means that people are using the correct criteria for initiating their referrals. And so obviously it goes through the different conditions that you would want to do a 2-week wait referral for. It tells you that you need to do a fit test before you refer for any of these conditions. And then there's a bit of information about tests that you have to do before initiating referral to try and make sure that the correct blood tests or investigations are present before the referral is made. And then where appropriate, we've included a bit of information either about moderate risk or medium risk symptoms, or in this case, there's a bit of information about when you might use a Q-fit outside the 2-week wait pathway. At the bottom of this section, we've got a link to the Northern Cancer Alliance webpage, which has some more information about fit tests and other things which are quite useful. And we're kind of encouraging people to use the template with the patient in the room, so it can be a discussion point or a reference tool. But it means that from here, you can actually complete the rest of your 2-week wait referral just from this screen. So obviously we've got our ICE requests. We can request our fit test from Gateshead, and then we can request our blood tests while we're here. And then the rest of the template is quite prescriptive, but we've had good feedback from people feeling that actually they're not sort of staring at it, not sure how to complete it. It's quite obvious as to what they should be doing. So step one, after deciding you need to make a 2-week wait referral, we've got the written information leaflets. These are quick print buttons. So if you click on that, you will get the printed information to hand to the patient, whether it's Newcastle, Northumberland, or whether they have a learning disability. And then obviously you can code that you've given the 2-week wait written information. Step 2 is all about safety netting. So although it's a small box, it is a trigger for the clinician to think about safety netting. Have I safety netted this adequately to the patient? So that's obviously the information that you give them about when you want them to come back to you, what you want them to do if they haven't received a referral. So we'd encourage people to do that, and then again, the correct SNOMED code is there for documenting that on the records. And then also we're encouraging use of scheduled tasks to follow people up. So this might be if you have a patient with a red flag that you're investigating, such as weight loss, and you want to make sure after their lower GI referral, you feel you've fully investigated their weight loss. You might send yourself a scheduled task for 3 weeks, 4 weeks to make contact with that patient and ensure you're happy that you've got to the bottom of things. The other time we're using scheduled tasks is with regards to fit tests. So for the indications where you require a fit test prior to referral, what we're encouraging clinicians to do is to explain to the patient they have a red flag symptom that needs a referral, advise them that they need a fit test first. But once we've got the result of the fit test back, we will automatically initiate the second part of the referral into secondary care. So the information to the patient is that if they don't receive a fit test within 2 weeks, they should get back to us. And if they haven't been seen in the clinic within 3 weeks, then again, or if they haven't received the appointment for the clinic within 3 weeks, they should either call the number on the leaflet or give us a ring back. With regards to relying on getting a fit test result back, clearly if it's normal, there is a risk that either yourself or another clinician might file that as normal and then not action it. So that's the idea behind a scheduled task, is that it will ensure that if you want to make a two-way referral with a normal fit, it will definitely happen. And then the last bit of the template is actually initiating the referral. So each different cancer has the correct link to the correct form. So these are the forms that were discussed earlier that are constantly kept updated. And again, it means that people aren't searching through all of the different forms in SystmOne. They just click this button and they'll get the correct form up. And then once that form's done, there is the button to send an urgent task to the secretaries. And again, that's a standardized task. So the secretaries will recognize that it's marked as urgent, and they're usually done within the same day. So on receiving that task, the secretaries will initiate that referral electronically. They will then add a scheduled task back to the secretarial group to ensure the patient's been seen in the clinic. If they haven't been, they then send a task to the referring clinician to review the patient and also add their name to a list so that we can audit this, and so we've got the information with regards to the QOF and the cancer DES. As a final check with this template, when we complete it and OK back to the patient's notes, we can see that it's put the correct codes on with regards to written information and cancer safety netting. Obviously, we can free text the symptoms and examination, but the cancer template itself leaves a code called checking procedure, which is a code that we use exclusively for this. And we run a search to make sure that anyone who's had the cancer template completed has subsequently had a 2-week wait referral made. And that's to try and make sure that we haven't missed any by not sending a task to the secretaries to complete the referral. Actually, since using the template, that hasn't been an issue because the task is right next to the form, but it still has been, you know, a concern with previous referrals and things. So that's the main sort of safety nets around the template itself. We also have a separate search that we run with regards to fit tests. Again, to ensure that any positive fit has subsequently had a 2-week wait referral initiated off the back of it, whether that be you know, that it's been missed and filed abnormally, filed as normal when it was abnormal, or whether it's been, you know, recognized as a normal result and the patient's been asked to attend and then hasn't. It means we can pick that up and ensure that anyone with a raised fit subsequently has an appointment with the colorectal team. So that's really the main look at the template. I mean, if I bring it back up, I mean, we've got all of the other different cancer sites there, but really they are exactly the same as to how they run and how they look. So I don't know if anyone has any questions or queries about that.
Thanks very much for that, George. I'm, you know, stuff like this fascinates me. I just wonder how much time it took to actually put this together and run it through as a project to get it into place.
So the bits that took a long time were taking the information from the Word documents and then translating the 2-week guidance succinctly onto a template that fitted into a screen you didn't have to scroll too much on. actually building a template doesn't take long. So one of the other partners here showed me how to build templates, and then I built it all myself. So it's not something that's particularly technical or particularly difficult to do. Yeah, I mean, we did it about a year ago, and then once it's done, it sort of runs since.
Thank you. And see, Sarah, you've got your hand up there.
Yeah, no, that's great. I think the helpful thing is having those guidelines at the point of referral, because as soon as you open the form and you realise that they don't fit the guidelines, you have to close it down and it's a faff. But just out of interest, will the guidance like sort of automatically update, or will someone in the practice have to keep an eye on when the guidance changes, you have to then update your template?
Yes, you're correct. So it won't automatically update, and that is the flaw in the system. But it means effectively I have to keep an eye on the forms and any updates. But to be honest, there's probably less error in that and disseminating that via the template than all of our clinicians individually having to learn the new guidance. But yes, I mean, that's something that it does require a monitoring.
Yeah, the only other thing I was just going to comment, we do this scheduled task about follow-up, but we actually, rather than tasking ourselves, we leave it as an admin role, because there's a risk, particularly with COVID, that you might not be at work, or you might be on holiday or whatever, and we worried that task might sit unactioned. So how we've done our SafeNet is that the scheduled task for follow-up goes to admin, and it basically says, please task the referring GP to follow this up, so that they at the time when that scheduled task arrives, they can see who's in and refer. Do you know what I mean? So it's even more of a kind of safety net.
Yeah, we run with a buddy system. So if someone's off sick or if they're on holiday, there is automatically another GP who checks your inbox. But yes, I mean, there's more than one way to deal with that. But yes, I mean, we don't want a task sitting there that needs action is the idea.
Yeah, no, really good, brilliant, thank you.
Thanks, Sarah. Thanks, George. Has anyone else got any questions that they want to fire out, or any of the things that are delivered today? Any comments? Any compliments?
Yeah, can I just say thanks very much again to George for sharing that, because I think actually really seeing things in action by somebody who's using it really makes sense and can understand how things work. As I say, I think, you know, there are other add-ons that GPs potentially have bought into, or CCGs are paying for at the moment, like Ardens or See the Signs, which work. But what would be really nice is for us to have an NCA-wide option that is available to use and doesn't require you paying for another service as well. So that's why we work closely with CDRC, which is the Clinical Digital Resources Group, to develop resources. So this is one of the things that we can look at with them. But we are also exploring some other options for using the 2-week wait forms, where it's like a decision support tool, but then we'll build the form in the background once you've put your information in. So we'll let you know more about that as those become available as well. Thanks very much, George.
We were, as meeting with Sarah, we were recognised as being one of the practices using the safety netting codes, and that's because I made up a couple of different templates for staff to use, just for ease of process. We have always used spreadsheets and the likes, but obviously we want to move with the 21st century and make things more auditable, to be fair. We still use the spreadsheet as a backup, but we found that the safety net and using the computer process, as well as having the paper backup, has worked really well. Fingers crossed we've never had to use the paper backup yet. But using the templates, making sure that everyone knows the template's there, is the main thing. That's locums and everyone who comes in. I've done it on an F12, so everything kind of works automatic just by pressing the F12 button, and the certain staff members have access to certain different templates and protocols on there. So for instance, if a GP wants to refer a patient on a 2-week rule, that'll, if they press their F12, it'll open up the safety netting recall, which then they can put in whether they want to recall them in 2 weeks, 10 days, 2 months, whatever. Admins search on that, the diary entry, every Friday. It also pre-populates that they're giving the patient the leaflet and explaining the information. It's pre-populating that they're giving the patient the information about why it's important that the safety netting happening, why they're being referred, what to do if the hospital doesn't contact them within 3-4 days to ring us back. All of that is pre-populated in ticky boxes that I've made in a template. So all that information is in there. The GP or the secretary, because some GPs do it themselves and some refer them to the secretary to do that. We can either text the patient the information through Accurix, which has been a godsend, or we can just print out the leaflet and give that to the patient and just write at the top to ring us if they haven't heard anything. If they referred on a Monday, to ring us by Wednesday afternoon if they don't hear anything. And that's really helped. Fingers crossed. I think we've only had a couple where there was some delay. I think it was maybe 2019 where there was some issue with referral to dermatology. I think there was some issues with there weren't enough clinics and there was some GPs, doctors leaving their hospitals and stuff like that. Where we maybe had 2 patients who hadn't heard anything from the dermatology clinic, but there was a clear reason why that had happened. So that's actually worked well for us. Next slide, I think. Please, yeah. So obviously we're keep the paper process as a backup. So when the GP has pressed his button and all the magic has happened in the background, that kicks a task to the secretaries, who will write it down in their paper sheet that they keep in their 2-week rule file, and add the information in, the date of the referral, where the referral's gone, what referral the patient's had, and if they've been given an appointment there, what date the appointment is. Sometimes a lot of referrals are deferred to provider if there's no referrals, if there's no appointments available, sorry. So them are the ones that we need to keep a closer eye on to make sure that they do get an appointment. And like I said, them diary entry in the background is run every Friday. And the secretaries I'm lucky to be able to give my secretaries time out to do this. They get an hour on a Friday to go through the searches, go through the 2-week rule file and just double check that everything matches. Everyone's got an appointment or everyone's been seen or they have an appointment. Next slide, please, Sarah. Thank you. Obviously, the referral process for the admin point of view is just to make sure that the patient demographics are correct. It doesn't matter how many times you ask patients to update the mobiles and stuff, people forget. Life gets in the way, but it's just really important that at point of referral that we do double check that the demographics are right. At the point of referral, just need to make sure that the safety net and code is being used, using the template, the information given, the importance of why and the time frames. We'll add a copy of the appointment to the patient notes. So from choose and book, you can save it to your desktop and then save it to the patient record. So you've physically got the appointment information there. The girls also print out. I know it's just duplicating and wasting paper, but the girls like to print it out and attach it to their spreadsheet in the file, just so they physically can see when they're signing it off that it's got a nice big cross through it and we can say that it's been done. And we do tell the patient contact us within 2 to 3 days if they hadn't heard anything back from the hospital. Obviously, if that's in the middle of the week, that'll get picked up on a Friday anyway, because we run the searches every Friday. So if the patient forgets to ring us, we ring them every Friday anyway. Next slide, Sarah, sorry.
Yep.
Thank you. As part of the safety netting process, we've also come up with a cancer diagnosis template that we use. This was just moving on from the cancer care review template that we used. And this actually helped with key worker information, what treatment that the patient has undergone and stuff like that. So this is just a little bit extra work that we're doing in-house. The template that I made also picks up all of the coding done before the 2-week rule. So that's the cancer safety netting, how long they've had the symptoms and stuff like that. So all of that gets picked up. So when a patient has an unfortunate diagnosis of a cancer, we'll catch this information that they were seen in the fast track clinic, what type it was, what the treatment intent is, that they've been given the cancer information. And then when the patient eventually comes into their cancer care review, all of this information is already in the records in one singular place. So the GP or the nurse practitioner or whoever's doing the review doesn't really have to look around on the notes to find that information. It's all there, easy for the doctor and the person to see that this person has undergone radiotherapy or they're awaiting radiotherapy, and what the treatment consequences of that is, and what the symptoms are of that, and what to look out for. That has been the best outcome from the clinician point of view. The patients have also found that we've done I think it was back in 2018 where we had some surveys done when we piloted the new template, and the patients felt that primary care, they didn't realise the amount of information that we knew, and they thought everything was just at the hospital and that we just knew that they were just having chemo and that was it, kind of thing. So the patient feedback that they had was they weren't expecting for the GPs to know what they knew what treatment they were on, what the side effects were going to be, how we could treat the symptoms and things like that. So that the patient outcome was positive for that. The patient felt more supported, and it was a win-win for us really, because the patient left feeling that they'd been listened to and that we were communicating with secondary care. The information that we get from secondary care isn't always quick and it isn't always timely, but we are working very closely with especially South Tyneside and Sunderland City hospitals with regards to certain tumour sites. And I've been working with them recently to try and get them to pre-populate some information that they send over for us. So for instance, if they do a holistic needs assessment, we're going to try and get them to read code it, so when it comes into the EMIS system, it'll already be read coded as a holistic needs assessment. Treatment care summaries for certain tumour groups. I think it's breast, bowel and prostate at the minute that we're working on. We're going to try and pre-populate them. We've already given them the code first, and there's just another couple of little codes in the background that we're wanting to pre-populate. So if a patient finishes their treatment, maybe for certain tumour groups that they mightn't have a long treatment, but they might be coming in for a cancer care review before the 6 months for some reason, that information might already be there, and that would be really, it'll help us, the doctors more so, it'll help the doctors to see where they are in their treatment plan. If the palliative, there's a little note on the cancer diagnosis template that I've made, that the palliative, what we have to do. It's quite clear that the RAG listed, we inform the district nurse, we add them to the MDT. All of that happens in the background with tasks, and that works pretty well for us as well. Next slide, Sarah.
Kelly, can I ask a question?
Yeah.
Can you see the chat?
Yeah, sorry.
All that positive feedback you're getting, just thought I'd let you know.
Oh, lovely. Thank you. Yeah, definitely be in touch, and I'm happy to send on any templates that you can use as a baseline, and then you can make them work for you. That's fine. This is just a little bit of summary of what I've just explained about the processes what we use in-house. I'm happy to send these over, these slides. But especially when the cancer diagnosed, with the new COAF rules and PCN rules, when we send the letter of the support, that triggers the diary entry for the cancer care review, and that code attached to that letter is the primary care support code, which I can send if people are not sure what that code is. I can send that on as well. And then once the person's diagnosed and they have that letter, that'll then gets copied to the GP, the referring GP, and then the referring GP will either ring the patient and ask them if they want to have a chat over the phone, do a video call, go out and see them if they're palliative, or for them to come in and have a chat if they feel up to it. If not, we just tell them that we'll be in touch for a more in-depth cancer care review at the 6 to 9 month timeline. Next slide, Sarah, please. Thank you. And this again is just a quick timeline of from referral to diagnosis, if that's what happens. So on day 1, the referral is made and the cancer safety net and code is applied, as well as the code for cancer information given, and to the discussion between clinician and patient, what to do in the event of, if you haven't heard anything, things like that. We don't just do the safety netting for cancers, we do them for if anyone's referred for an urgent ultrasound, urgent x-ray, any scopes, vague symptoms. We use this process for all of that. Fit testing, if they're doing symptomatic fit testing, we use it for that as well. From day 10, the diary entries run, or the Friday for the secretaries, but I've got 2 admin working, so secretaries do their recalls, and myself and another girl who does all the cancer stuff runs the diaries at day 10. Between day 14 and 21, we just check to see, have we had any correspondence from the hospital yet? Has the patient attended the appointment? If not, we ring the patient and ask, we text them, we speak to them. Day 21 to 31, we normally do have confirmation back by then, whether or not they've had a cancer diagnosis or they're still awaiting ultrasounds, CTs, MRIs, scopes and things like that. We'll add another diary entry for another fortnight, just so we keep checking. Once we've had, normally by day 60, you've had either a diagnosis or no, there's no cancer there, but they're under review for something else. That's great. If they're not under review for anything else, but they're still having some kind of vague symptoms, that goes back to the GP. And then there's a task sent to the admin group if the GP wants to keep an eye on that patient. And that's worked pretty well for us so far. Next slide. So, thank you. So the team involvement, it has to be a multitude of staff throughout the practice who is involved. The referrals is obviously between the GP and the secretary. All incoming mail flows. There's myself and another 2 members of staff who were part of the cancer group that I've made on our workflow. So there's a cancer group where we send the mail to, and we use the templates to do the diagnosis and moving the letters around backwards and forwards where they need to go to. And recall system, we'll have a paper log, secretary and the practice nurse does the big spreadsheet what we use for the, I'm trying to think, it's the National Cancer Data Collection. Yeah. And our practice nurse does that. So obviously we've got a triple process there where I do my stuff, the admin does theirs, and the secretary and the practice nurse does theirs. And then obviously if it goes to palliative, it's the GP. We've got 2 admin who attend the MDT with the MDT coordinator, district nurse and the palliative care nurses. Next slide, Sarah. Thank you. If anyone has any questions, anyone has any queries or anything like that, I'm really happy to share any bits and bobs. What I have, I'm happy to share anything to help. Thank you.
That was brilliant, Kelly. There must be some questions. Please take yourself off mute.
Most just saying wow.
It's
wow.
It's really good care, Kelly, and it seems to be really rounded as well, so that you're hitting every person that's involved. Well done. And I would really like to copy it in our practice.
Hassan's got a question, if that's okay.
Hi everyone. Yeah, just want to echo everyone else's thoughts. Say what a fantastic process you put in place. Really, really well thought out, and it must have took a lot of effort to do all that, and really sets a great example for the rest of us to follow. And yeah, if you could please share those, that would be absolutely brilliant. Just a quick question I thought was on a PCN level. What were things that we're looking at is specific cancer care coordinators, and if we look at this process, you're quite lucky. You mentioned you've got a lot of admin support and secretarial support. How would you see something like care coordinators fitting in and helping patients navigate it, but also helping us sort of reach some of these sort of targets and stuff, especially post-diagnosis? Do you think there could be a role for people like care coordinators to help practices and PCNs do this sort of thing?
Oh, 100%. At the beginning, setting up all of this, setting up the process does take a lot of work, and it takes a lot of time out. Once the process is embedded, it doesn't actually take a lot of time. It's literally possibly an hour a week, not even that. And the hour a week is maybe some of the, if there's a lot of referrals, but it's very rare you get a lot of them kind of referrals. The process that takes the longest amount of time is looking for the vague symptom referrals that we've done. So if a doctor's done an urgent x-ray or urgent ultrasound or something like that, it's that takes the time. The necessary 2-week rule side of things, it's pretty quick because it's all done by searches, recalls, codes, diary entries, and you're just pressing a button and ticking the box off. But searching through the test requests to find certain tests that have been requested is a bit monotonous, because not all doctors use the template, although we're trying to get them to use it. But this is the field safe that we have to make sure that we'll go through that thing. And it does take a little bit longer, but we're kind of running with it now, and we'll barely spend more than a week on that.
But I'm thinking if a PCN or all the practices in a PCN have the same process in place, then you could have one sort of central care one that could do that for all the practices in that PCN, specifically for it, and that might work quite well, and it might reduce some.
Yeah. That, I mean, that's what
theory,
we all want, isn't it? Yeah.
Yeah. Thank you very much, Kelly. I'm going to move on now to Dawn. Thank you very much. If there are any extra time at the end, I think we've probably got about just over 10 minutes left. So if there are any questions, we'll come back to you. But Dawn, thank you very much for joining us.
No problems at all, Sarah. I'm a little bit gobsmacked, and I might be lost for words for the first time ever. Thank you very much, Kelly, for that. We're not doing as good as Kelly is, but we're on our road there, and I think that's probably where all of us, who are saying wow to Kelly today. So really, I just wanted to explore probably some of the things we've already explored. Really, one of the big things that we found in practice was just like Kelly had said, and I think you reiterated just before that GPs are renowned for not wanting to use templates, and to try and engage the GPs onto using the templates was quite the biggie that we had. So we initially ran an audit just a few weeks ago, actually, and then we brought that to an education session within our practice meeting, to show that actually our locums were putting this to shame. Our locums were using a safety netting template where our GPs weren't. So one of the regular GPs was using it, and the locums, and the other GPs and AMPs weren't. So we then took the GPs through the template that we use. So I'm actually not sure, Sarah, whether it is the Macmillan safety netting template that we use, but would it be okay for me to share my screen? So I'll just see if I can share my EMIS screen. Bear with me, because I'm working from a caravan, guys. So if my EMIS doesn't come up, I do apologise, and hopefully you'll all be seeing my EMIS screen now.
It's working on it, Dawn. It's working. Yes, brilliant.
So this is the template that we use. We've actually adapted it because there were a few codes that seemed to be missing. So actually the cancer safety netting code was missing, the SNOMED code for that was missing. And we also changed some of the wording to reflect what we call our vague symptom pathway within South Tyneside. So ours is currently called the rapid diagnostic pathway. So we wanted to label it as that on the template. And the benefits of this is that I know that Kelly was just saying before that it's difficult to sort of track the vague symptoms, and obviously the fast track referrals are quite easy to sort of follow up, and this allows you to put in a due diary date in. For example, we've added this part on here to ensure it's kind of teaching your granny to suck eggs, that you would inform the patient that they've been referred on a suspected cancer pathway. And like I said, we added the cancer safety netting tool within there as well. It also allows you to do the diagnostics when you're referring for a suspicion of cancer. Admittedly, you're not always referring for a CT scan on the suspicion of cancer, but maybe a stone, for example, so wouldn't be appropriate for that, but allows you to type in things for like a CA1T5 if you're doing the fit testing, how you're going to recall the patient, and allows free text into that as well. Also allows you the safety netting of symptoms for some active monitoring of the patient, but equally if you're just looking at things that potentially you suspect might need to be followed up. So allows you to type in things, and if you actually use the template, for example, I'll just forward this by 2 weeks, and if we save this off, in the alert box, it actually then gives you the safety netting alert in the right hand corner, or should do, hopefully. I'll just see whether it'll come up now. Hold on. I'll just go into that. Sometimes my EMIS runs a bit slow. Sorry, like I said, I'm working out of a caravan at the moment. So I'll just see whether it'll come up. So as you can see here, a safety netting code suggested that I've made a cancer referral, which appears in the due diary dates and can be searched upon. And then obviously can be cleared once that information's come through. So we've found that to be really useful. What we have done is made a couple of little crib sheets for the GPs that kind of sits on top of their computer screen to tell them which templates to use for certain things. So not only for our cancer safety netting, but for our palliative care template. We're lucky to have a really well organised palliative care template now in South Tyneside that generates our computer generated Cardexes, do not resuscitate forms, EHCPs, etc. So that's fantastic, and we've got all of those sort of printed out on a little card that's very high tech, blue tacked to each monitor screen, in the hope to just advise the GPs and again the regular locums that we use. Our admin tend to manage the searches. We're just starting those off, and I'm conscious that currently we run those monthly, and we might need to look at that a little bit more closely to ensure that we're trying to get that loop maybe weekly. I'm not sure whether we would run it weekly, but maybe 2 weekly. I think staffing issues are quite a big part of that at the moment, and getting the staff up to speed, because obviously they're always being, when you're short staffed, they're always being called to the phone lines as well. Like I said, we had to tweak the template that we use slightly, that we just to sort of mimic what we're doing in practice. We do keep a spreadsheet. We do use AccuRx for sending things over. We have found a few of our elderly patients who maybe live on their own and don't have family support, our secretaries actually support them to chase up their 2-week wait appointment. So they will be in regular contact with our older population, or maybe the hard of hearing or hard of seeing, or those who we think might struggle knowing our patients, to say, can you chase up? Because a lot of our 2-week waits at the moment are send for triage. So there is always the sort of, if you haven't heard by a certain date, please call this number. But we tend to pick up on the calling the number for those patients who we feel would struggle. In our practice, we discuss all the new diagnoses coming through, and I think correspondence is a big thing. So I'd be really keen to pick up, you know, with Kelly around what they're doing with the hospitals, because I think that would be really useful to have things pre-populated. Love the idea of us having, you know, that information you know, of who their coordinator is, who their sort of lead sort of cancer therapist is, who their named nurse is, at the point when you're having a cancer care review, because there's nothing worse than as a GP having to troll through 3 or 4 duplicate potentially letters in the EMIS record to try and find the information that you're looking for, so that you don't sound really ignorant when you're talking to the patient for the first time. I think, you know, there's some robustness around, you know, using things like Excel spreadsheets, but I think by the sounds of things, Kelly's nailed it. And if Kelly's willing to share a lot of that information, I think we could all nail it, because it sounds really quite robust. I think it's just about us obviously putting those processes in place. I think the biggest sort of hindrances to us are lack of correspondence, when sometimes that important notification of diagnosis hasn't come through. And also the potential, you know, we talk about the diagnosis of cancer, but also a lot of those 2-week waits don't transpire into cancer. And the follow-up of those patients as well, because equally, you know, important that their symptoms are potentially still there, you know, we've still got to follow up on that. From our perspective, we I do my own referrals, and I do find that that works really well. If you, as a GP, you can do your own 2-week wait referrals and attach your forms, trying to teach the other GPs that it's actually really easy to do, and that way no 2-week wait is going to be missed. But we have had some 2-week waits being missed. We now keep on our screen, I've anonymized it, so you can see today we've got a referral clinic on our EMIS, so any referral that we make, any correspondence that we send to our secretaries goes on there, and then it's highlighted that it's a 2-week wait. So I think, you know, trying to convince GPs that it's a really good thing for them to do their own 2-week wait's been difficult. I mean, but it's much easier if you do your own. You attach the form, everything's done and dusted. You can attach any letters that you feel are pertinent, rather than having the secretary having to figure those out. I think what I hope that we would sound good coming into this meeting today, but Kelly, you've put me to shame, honestly.
Oh no, that's brilliant what you're doing.
But I have to say, you know, just so those first few steps into it. I mean, I'm quite involved with our sort of PCN, and you know, some of the things our PCN have been asking for, we've reported back. It's really difficult to audit some of the things that they've asked us to audit, even though we were the ones that selected those things to be our auditable things for this year. So I think it is important for the PCNs to work at scale on this. I like the idea, Hassan, of having the care coordinators involved. I think that would be really important to do. And, you know, just working a bit more closely and using our EMIS. I mean, EMIS is not necessarily always the best system, obviously, as I'm sure we all know, but we've got a lot of information out there that maybe we could work together to sort of share information with, from our community teams, etc. But yeah, I was just wanting to talk, Sarah. I don't have a presentation. I'm happy to answer any questions, but I think Kelly's our oracle by the sound of things.
I think it both exactly what you've both said. You both have, you know, it's really highlighted what can be done, and we're not all at the same position.
We thought we'd look at some clinical scenarios just to try and make this real. I know we're, rather than talking about things esoterically. Could we press the next slide, please? Thank you. The first one is a common one, you know, chest x-rays. We often do a chest x-ray and we're told we need to repeat that chest x-ray in 6 weeks' time. In Newcastle, we're allowed to order CT scans. One of the downsides of that is occasionally we get told, oh, there's a nodule. You need to repeat the scan in 3 months' time. One thing you have to do is make sure that these things actually happen. And certainly in my own practice, I remember a few years ago, one of the patients needed a chest x-ray. I sent the form off and I then crossed it off my list of jobs. The patient did not attend for that chest x-ray, but came in 3 months later with a lung cancer. So we've all been bitten by not following these things up. So questions are, what would we do in these situations? I've got press the next slide, press or next bit. Yeah, so most of us now will have some kind of safety netting. We've discussed a lot about 2-week referrals, but we also need to do it for certain investigations. And we had a very good presentation talking about how we do follow up blood results, CA125s, and urgent scans and things. So some people will use a spreadsheet in their practice. Some people will task themselves or task a group. Can I press again, please? And we did also mention this on our breakout room about locums, or if you go off sick. You don't plan to be sick, but sometimes you task yourself. But if you go off sick, what's going to happen? Who's going to follow that safe netting up? So we need to have robust systems in place for all these situations. And these are all things which we do every day of the week. Can I have the next slide, please? The NICE guidance is very clear about this, is that if we order a test, that our job is to basically to look at the responsibility of looking at that result and ensure it's acted upon. But it also mentions that sometimes tests can be negative, and that can be a false negative, so for chest x-rays and FOBs. And the other thing that it talks about is the importance of that following up people in a time frame or appropriately if their symptoms are not meeting the referral for criteria, but are still abnormal, all the things we've discussed before. Next slide, please. So patient, COPD, you do a chest x-ray because of recurrent chest infections. It comes back normal. What do? We all know there's a risk here. Can I have the next slide, please, or next press? First thing is about, you press?
We're going to have a poll here as well.
Oh, a poll, sorry. Chest x-rays, thank you for reminding me. Is Pete there to press the poll?
Yeah, that poll's just coming up now, guys. And the question is, a negative test result doesn't always rule out cancer. Evidence suggests that a chest x-ray could be negative in up to how many cases? Your time to decide, 10%, 40% or 23%. We've had 9 responses so far, 100% for 23% coming through there. A few people now saying 40% and less people saying 10%. 20 people responded so far. That's 83% of people are saying 23% is the answer to that question.
And that's the magic number, as they say. So we do know this happens. You do get people who have a normal chest x-ray, but will still have a lung cancer. So yeah, what do we do with these patients? Because the patients are so important. We mentioned before about following up patients with symptoms. So we have to plan what we're going to do next. Can you press the next button, please? Thank you. So one of the things you may want to do is to task a group or to get the patient to come back, or have a plan review. Sometimes you'll say to a patient, come back if, but sometimes with some patients you'll say, no, this is a high risk. I'm going to book you in. I'm going to set a set time to bring you back and see how you're doing. And that's certainly the case with things like weight. You want to just monitor somebody's weight. This patient may have other symptoms when they come back. They may have hemoptysis. Therefore, with a normal chest x-ray, they still need a 2-week referral. Certainly in Newcastle, if they have weight loss, they could then meet the criteria for the non-specific symptom or the RDC pathways. All things we know, but if you don't see the patient again and ask those questions, you may miss these things. And if the patient doesn't meet the criteria for 2-week referral, but you're still concerned, you can refer. It may not be a 2-week referral, maybe a routine referral, or it may be advice and guidance saying, I'm really worried about this patient. This is the clinical situation. And certainly I find that in Newcastle, when I write to my colleagues at the hospital, they do come back with quite sensible ideas and plans about what to do. The next slide, please. Thank you. The other test we talk about a lot is FIT. If we arrange a FIT test, what's our responsibility? Have a next slide, please. Thank you. If we request a test and we think it could be cancer, then it really is an important diagnosis. We can't then ignore it. But we have to find out if it's not done, why hasn't it been done? And there may be good reasons for it. Can I have a next slide, please? Thank you. And it may be the patient hasn't received the test because it gets sent in the post. It may be that they need some reasonable adjustment to actually get the test done, and we've missed that. And they have learning disabilities. It may be they're very scared about the result. And certainly I see a few patients who won't do the test because they're scared about the result. And we know that the Northern Cancer Alliance has built in these reminders at the Gateshead lab that we get that sent to us. And they do remind us to chase things up. And they're quite useful. And that's probably the only test that we have reminders for. We don't get that for urgent CT scans. We don't get that for CA125s, other things which may suggest cancers. So it's an extra situation. And the other thing we have to remember is that we can't make a patient go for a test. And sometimes you can have a long conversation with the patient and they can know that you want to do it. They'll still say no. And that's completely acceptable as long as they understand the risks that they're taking and you've clearly explained to them why you're doing it and what's the purpose behind it. If they still say no, that's completely fine from that point of view. But you may want to bring them back and you may want to say to them, if the other things change, you get more worried. So you still may not leave it at that, but you may continue to watch them. So the safety, letting a FIT test, if they're positive, I think we all know that we should now do a 2-week referral. If they're negative, they still, well, first thing is, if they're negative, but they've only got mild symptoms, which is change in bowel habit or rectal bleeding. If they've got a negative fit test, the chance of having cancer is very low, under about 1%. So you may want to say to this group of patients, or say, if you begin to get weight loss, if anything else changes, then you need to come back. And obviously in these situations, you need to be careful. You need to have an examination, because if they've got an abdominal or rectal mass, that obviously would mean they need a referral. If they've got a negative fit test, but they've got iron deficiency anemia, that's still a 2-week referral. If they've got an abnormal examination, if they do examine them and find they've got a rectal mass or a mass in the belly, they still need a 2-week referral. These things we do all the time. It's just how we work these safety netting into our clinical practice. And as I said before, we do this in all the medical problems we see, whether it be a child that's ill. We're always safety netting. And so working out plans and actions about how to be sure that we're not missing anything that could be brewing in the future. This patient could come back and have weight loss, as we said before, and then they would go down the non-specific symptoms pathway. And I think a lot of areas now are calling it their new diagnostic center pathways. And you have to also remember that with this change in the lower 2-week referral pathways, previously when we used the old criteria without a fit test, 16% of the patients who referred had a different cancer. It may be an upper GI cancer, maybe hematology cancer, maybe ovarian cancer. So yes, we can say the fit test, they may not have a high risk of a lower GI cancer, but they could have a very high risk of another cancer. And that's why it's worth thinking, why am I seeing this patient? What are the symptoms? Do I need to do anything further? Do I need to do a chest x-ray? Do I need to do a C125? Do I need to check their urine for blood and things? So just thinking those things through rather than just saying, oh, negative fit, I can forget about the patient, because we may miss a cancer which is brewing. Have a next slide, please. So I'm going to pass over to Katie to do the next slide.
Thanks, Chris. Dawn made a really important point in the chat box there about gut feeling being really important as well, and that's recognised as having a high positive predictive value when you're thinking about referrals as well. Amos has asked about the serious non-specific symptom pathway. Now, that is being rolled out across the region, but it may be variable about access at the moment. So it depends where you are, whether that's been launched yet for your CCG. So yeah, just thinking about hematuria, and this is absolutely hot topic as well. So we've probably all heard in the news and in various other communications about the drop-off in suspected cancer referrals that happened at the start of the COVID pandemic, and a lot of those referrals have recovered, and we're sort of back to normal levels for a lot of the cancers. But where the big gap is still, one of the big gaps is in urological cancer, particularly prostate cancer. There's going to be a Help Us to Help You campaign starting in the next week around urological cancers. And we also know that from past experience, SERMS reports, one of the common SERMS reports has been around missed urological cancer relating to identifying hematuria. And this is just an example of how that can easily happen. You know, you've got somebody who picked up at a chronic disease review is having some blood in the urine, but no other symptoms. The urine then gets sent for an MSU, which comes back and is filed as normal. And you know, and actually maybe even the repeat urinalysis had been requested and handed in, and that was negative, and then no other action was taken. But actually, to complete there, really there should have been a third sample there as well. And you know, you can then get people presenting again later on with cancer that maybe had a missed opportunity for an earlier diagnosis. So hematuria processes, I think, are one of the really important ones for us to think about in primary care, about how we manage those. The other thing is about our opportunities to do urinalysis as well at the moment, if we're thinking about a lot of missing urological cancers. So because we've had less chronic disease reviews, and now with the blood bottle shortage, we might be seeing less people. So just think about what are the opportunities to check for blood in pee, and what's our safety netting process for following up for that. And you know, we've seen some examples in the breakout sessions of the safety netting templates that would help us to do that as well. You can go on to the next slide, please. And again, this is one, we're just going back to the referrals again. So, this is a patient who was referred. The practice was informed that the patient hadn't responded. A repeat referral was made, and then there was a further letter to say the patient hadn't engaged to book an appointment. And it was 4 months down the line by the time somebody contacted the patient, and it turns out that actually they just weren't able to read any of the letters or communications that they'd had through. So we've missed the opportunity to flag up that adjustment that needed to be communicated to the patient and to the hospital about how to engage with this patient. So there's an avoidable delay, and it's just back to what we're saying about a non-attendance doesn't mean that that's been an informed patient choice. If somebody has memory problems or mental health problems or learning disability, then or if they haven't been given the information in a language that they understand, or for patients who are deaf or blind, being given information in an accessible format as well. And just remembering it's with our we have the responsibility to provide the information in a suitable format. Okay, I think that's probably the last scenario there. So,
Kate, I've got one question.
Yes.
There's Dr. Dan and T's asking about non-specific symptoms. Is
Yeah.
the combined pathway up and running yet there with the non-specific symptoms?
Okay, so this is something that maybe not everyone's come across yet. There's been some work over the last 18 months for us to develop a combined GI symptoms pathway so that we end up with a single referral point from primary care for GI symptoms, and this is to try and address the overlap that exists between upper and lower GI symptoms and to try and get people to the right test at first straight away. Whereas what we have at the moment is we have a number of direct access tests or straight to test referrals that we can do, but it doesn't necessarily answer the question that we're asking for that patient. So for instance, somebody with weight loss and abdominal pain, we could do a colorectal referral, we could do an upper GI referral, we could do a CT pancreas. We obviously would need to do a CA125 or PSA, things like that. So how do we try and streamline that experience for the patient about their investigation? So we've been working to develop this pathway. There's been a huge amount of engagement from secondary care and lots of input from primary care as well, and our lay reps. And we've now developed a pathway and a new referral form, but it may not be available to you yet. So I think Tees Valley are likely to be the first CCG to go live with this, and that's because secondary care is sort of set up and ready to go with it. It's possible that Northumberland, North Tyneside might be next. I think Tees Valley, probably then Durham, and then maybe Northumberland. But watch out for communications from your CCG around this. The referral criteria are the same as they are. We're not changing the referral criteria, and it still relies on the use of FIT in primary care to help with that decision making about referral as well. But you'll see that it's hopefully a bit more streamlined. Hope that answers the question.
It does. I think Dr. Paul hasn't had any information in the Tees area, so perhaps we'll get Angela or somebody to get in touch if that's okay.
Yeah.
So the summary of today's meeting, we wanted to make people think about things. We've seen some very good presentations, certainly in the EMIS side. I'm sure you did on SystmOne as well. Can the next slide, please? What we'd like you to do is take away 3 points. What 3 things can you take away and improve in your practice? If we're all perfect, that's great. You don't take anything away with you at all. But like most of us, when we certainly saw Kelly's presentation, we all felt that we were all rubbish because she's brilliant. And her system in place is absolutely unbelievable, I have to say, for EMIS practices. But yes, can we take 2 or 3 things away which we can implement in our practice and our PCN? It might be adding in the read code. It might be just making the systems more robust. It may be looking at templates. Rather than just go away and forgetting everything we've done, take things away, take them back to your practices and take them to your PCNs and try and improve things. It will improve our lot as doctors, but it'll also improve, more importantly, the patient's outcomes and the patient's quality of their care as well. This is the whole point of why the government saying it's not just for to tick a box is to improve outcomes for patients. So please do think about what we can take away and what we can improve. I've certainly got things that I'm going to be taking away from today's meeting. And after that, we're open to more questions. So please do ask questions. You can either put your hands up or you can put them in the chat.
And just to say, I know we said at the start, all these slides are going to be circulated and available to you. And there are a number of slides at the end of this presentation that have got some resources on and some links on. So Sarah's just whizzing through those for us just now, but just definitely please use this pack as a resource to go back to and to help think about safety netting in your practice. And yes, any questions, just pop them in the chat box.
There's a couple of people asking for the link for AccuRx and the user guide for the dashboard, so we'll make sure that they are circulated with the slides. I think you've pretty much covered all of the questions that have been coming through. A couple of words were the easy read and the change of the format, the leaflet, so that was useful.
At the moment, I think everybody's still got access to AccuRx, and I don't know if it was touched on the EMIS meeting, but there is a pathway in AccuRx which will send an initial text to a patient, reminding them about the urgent referral, and then there's a follow-up text automatically sent in 2 weeks. So that again is quite a nice, neat way of safety netting the referral with the patient as well. If anybody isn't already using that.
Yep, we can share.
Yeah, I think AccuRx Pathways is really useful, I think, for other things as well, you know, like the fit test, you know, particularly if a fit test is negative, you know, that kind of thing. So we use it huge amounts in our practice, and I just hope our CCG continues to pay for it.
Yeah, agreed.
I know that unless there are any questions, and we had to leave, we were that engrossed in the presentations in our breakout room. If there are any questions that didn't get asked in the breakout room, feel free to use the last few minutes now to ask those. Sharon has just put a feedback form into the chat box. If you could please click on that and give some feedback regarding today's session. And I think Pete might have one last poll as well for looking at future kind of webinars, what your interest may be, but I don't want to overdo things. Oh, there it is now.
Indeed, yeah. Just pop it up on the screen there. My last poll for you all. Thanks for letting me do these. These really do keep me motivated and excited. So the last poll there is, you know, we're looking to run another cancer PCN update in February 2022, and we're just asking for you to specify what you would be interested to hear more about. Multiple choice, so fill your boot, answer as many as you want. But if you do select other, please just let us know what you would like us to cover in the chat box, and we can make sure that we can accommodate that moving forwards. Thank you very much.